Hi, I'm Earl Silberman, editor-in-chief of the Journal of Rheumatology. And for the month of August 2021, I picked two topical and related articles on COVID-19 vaccination in patients with rheumatic disease. Today, I'm interviewing Dr. James Galloway from King's College London, England, who is the senior author of an editorial by Bechman, Yates, Bukhari, Winthrop, and Galloway entitled "The COVID-19 Vaccine Landscape: What a Rheumatologist Needs to Know." This paper is available for viewing on the journal's website at jrheum.org. So, Jim, I want to thank you for taking the time to speak to me and the listeners about your timely and even more timely, as time goes on, editorial on vaccination in COVID-19. I'm not going to ask you to review all the vaccines available, nor their efficacy, and as I'm sure the listening audience is well familiar with this, but rather deal with specific issues raised in the editorial. Your editorial ends with key takeaway messages, and could you please summarize them and update them as you see fit?
Well, thank you very much for inviting me here, and thank you for publishing the editorial. As you sort of mentioned, that it is a very timely question, as across the globe we're seeing this enormous rollout of vaccines against SARS-CoV-2. The key messages that we wanted to convey in the editorial is that whilst there are definitely uncertainties around the vaccines in our patients on immunosuppression, particularly uncertainty in terms of how effective they'll be, the risks are outweighed by the benefits. And even though vaccine immunogenicity may be lower, it is likely still to be of enormous benefit. The other thing we talked about is whether there was any rationale to choose one vaccine over another. And our message was, at the moment, there isn't evidence to support choosing one vaccine over another, and really a message to take whichever vaccine is offered if you are a patient with access to a vaccine. And the other thing that we touched on was about whether there should be any DMARD interruption. And again, there is at the moment still a lack of evidence, although there's a little bit of data for methotrexate interruption that some clinicians might use to inform their plans.
Yeah, that last point is really tough, especially with long-acting DMARDs with long half-lives, So anyway, it is a tough point. So in Canada, our government had mandated dosing intervals of approximately 4 months, 16 weeks to maximize the first dosing. Well, now that we're actually getting up there with other countries in first dosing, I'm happy to say, they now are recommending timing more in line with the manufacturers. I know there's some data has come out of England and some other countries about potential optimized timing, whether it's the 3 to 4 weeks for the mRNAs, or slightly longer for the AstraZeneca Oxford vaccine. Would you wish to comment on any updated information you might have, especially for rheumatology patients on potentially immunosuppressive drugs?
So as you said, in England as well, we have also moved to a reduced dosing interval back to more in line with what the clinical trials did, particularly for our younger population. There's a really important bit of immunology that we've known for decades, back from the 1990s with hepatitis B vaccine trials, that spacing, increasing the gap for the prime boost interval probably does create a more robust immune response. And that so if you wait longer, you've got a better chance you're going to mount a robust and probably a better longevity IgG response. So you would actually think that in our patients who are immunosuppressed, there may be a particular advantage of increasing the prime boost interval. That's not based on robust scientific evidence. And I think the challenge with COVID-19 is this balance between vaccinating as many people as possible. And you could make a very strong argument that for our patients, whilst on the one hand you want to give them an individual protection, it is probably the herd immunity, having enough of the population vaccinated, which is going to maintain very low community circulation of the virus, that may be more valuable. So I suspect at a public health level, it is our government's making that decision to get as many people vaccinated as possible is probably the overriding sort of principle.
Yeah, I agree. It's tough. These are very tough calls. And of course, we're in an area that we have no experience with. And as you said, as an immunologist, the Pfizer Moderna timing made no sense to me. I understand why they did it, to get it out as fast as possible. No, that was logical, but not immunologically speaking. So we shall see as time goes on. I mean, one of the things that does brought up, especially with people who have lupus anticoagulant or otherwise hypercoagulable, was the use of the AstraZeneca. And I guess the Johnson & Johnson in the US has been associated with the blood clots. So our government actually came out with a rather controversial, not controversial so much as I think emotional statement when the head of, it's called NACI, which are National Advisory Council, the head of it actually said, I wouldn't give my sister a second AstraZeneca shot, which I sort of said, wow, now that's really crossing the line of science into personal. But so now our government has really come out and said that the second dose should be an mRNA. So it brings up the whole issue, especially in our patients again. Is that logical to switch modality, to switch vaccines, even if it's within the mRNAs for our patients in particular? Any comments?
Yeah, so I mean, the AZ thrombosis story is it's been a really tough one. Back in January, I saw a case of venous sinus thrombosis following a vaccine, and on the one hand, there was a bit of me that said, well, almost everyone I see clinically has had a vaccine, so the cause and effect is very hard because everyone's had the vaccine, so anything you see is going to be post-vaccine. But it was such a rare phenomenon, and as we've seen the story unfold, it is a really, I think there's a very clear message that there is a small but detectable effect in terms of the risk of central venous thrombosis, and that becomes a really difficult one when you look at younger populations who are healthy without risk factors for severe COVID. So I think in someone who's 75 with comorbidity, then the risk benefit is clearly in favor of vaccination. And in someone who's 25 with no comorbidity, then actually I think, and the UK have said that they're not recommending AZ for people who are young. And the second dose thing, so that I think it's a very natural instinct. If you have a safer available vaccine, and we have to be aware that globally we're going to need all these vaccines and more. So I think it's not that, I think people will want to use the vaccines at a global level, but in countries where there is, in some places, abundance of vaccine, and you have a choice to use an mRNA vaccine, it's very appealing. And the New England have just published a beautiful paper looking at a switch dose where you give two different vaccines. And going back to the hepatitis B, of course, in someone who is a Hep B non-responder, we give them a different brand of Hep B vaccine because we know that if you give some immunological variation to what you're exposing them to, your prime boost is even better. And that study showed exactly that people who were given AZ first and then mRNA second had a stronger immunological response to people that had same. So I think immunologically, you're probably slightly more likely to have vaccine-related side effects, fever and post-vaccine myalgia, but you'll probably get a better immunological response. So I have no concern about switching vaccines from a protection perspective.
Yeah, no, that makes a lot of sense. Of course, that's in countries, as you said, with lots of vaccine. And not only that, who can actually store the mRNA at the appropriate, which doesn't apply to a lot of the world. I mean, that's a big issue. But anyway, and it does affect our patients, but certainly when you have no choice, it's great. The interesting thing is an digression, I was discussing this with other people, this idea of the HIT, the heparin-induced like syndrome, it's probably less common than with heparin, which we give all the time and don't tell our patients. It's just an aside to all this. Here we are worried about something which may be at the most 1 in 50,000. And heparin-induced HIT is higher, and we don't warn people. So just an interesting point. Anyway, my last question, I think you addressed this a little bit, but we'll get into the idea of a booster dose. Should our patients get booster doses for significant immunosuppression? I know that they're certainly highly considering, if not actually coming out with it now, for renal transplant patients, as we're all aware of. They're the highest risk. It floors me how vaccinated patients are. It's amazing risk who are not only renal, but all transplants, and people with cancer. So I just wonder if we should be advocating more. I know there's no data yet on the second booster or third vaccination.
Yeah, and I think in our setting, the area we've particularly been watching is with rituximab, where we think that might be our niche within our autoimmune disease subset, who may be more vulnerable to the virus despite vaccines. And I think that the data that have come out of oncology and, as you say, the renal transplant, where there is now very convincing data that 3 doses as an initial regime is much better than 2 at mounting a significant antibody response, there's a rationale for it. The flip side of it, though, is, of course, that we've also seen some very convincing data now that there's very little waning in IgG titers out to 8 months in people immunocompetent. And I think the big question is, when do you need to do the booster dose? I think it's quite likely when you look at, when you look at the IgG responses to SARS-CoV-2 vaccines, the responses are striking. It's a lot bigger in most people than you get from wild type from natural infection. They're very immunogenic, particularly the mRNA vaccines. And the other side of it is we have seen these small but detectable adverse events. There's been the concerns about myocarditis emerging. So I think there's a balance. We don't want to overdo it. I'm sure there will be a need for a booster. I think the studies are starting to come through. I'm sure that booster will be best targeted in the most vulnerable and those people who are most likely to have failed in an antibody response. I'm curious about whether measuring antibody titers, which we're starting to get better at doing, is going to give us a guide to who's in need of that booster. Because it may be that for healthy people, and that could include people, for example, on many of our immunological therapies, a booster may only be needed every several years rather than once a year. And we might be better in getting global vaccine coverage rather than triple dosing people in high-income countries.
Yeah, there's always that, are we even for your own country when we have the resources, being selfish, but actually shooting ourselves in the foot in many ways by only worrying about us and not the other place in the world where new variants might come up. So do you have any other comments or issues you'd like to raise for our audience before we end this?
No, other than an enormous thank you, because I'm aware that from an editorial perspective, this has been a very busy year and a half or so. So yeah, thank you. And thank you very much for inviting me to come and talk to you.
Well, and thanks for writing the editorial, which, as you and I know, was initiated by you, and that's greatly appreciated by your group. So I want to thank you for taking the time to talk to me, and to our viewers, please read the editorial entitled COVID-19 Vaccine Landscape, What a Rheumatologist Needs to Know by Bechman and colleagues. In addition, please read the article entitled The Canadian Rheumatology Association Recommendation for the Use of COVID-19 Vaccination for Patients with Autoimmune Rheumatic Diseases by Hazelwood on behalf of the Canadian Rheumatology Association, and listen to my interview with Dr. Hazelwood about this article. We'd love to hear your comments on Twitter at jroom or by email at manuscripts@jroom.com. And I want to thank you for joining us and hope you will listen to both interviews. And please join me next month when I'll speak to one of the authors of one of my September picks. Bye for now. So this went on too long, so my tongue gets tied sometimes. Bye-bye.